We had major improvements in neonatal care and outcomes of babies between the 60s to the 90s. Starting around the 1990s, we've had no improvement in outcomes. So for 20 years, we've actually been static. That's worrisome given that we've been investing a great deal of new monies, technologies, efforts into trying to improve outcomes. And many people think that in fact we've reached a plateau in our current technology, that unless there's a new leap in technology that we will not be able to make new improvements in outcomes. So we've been looking around actually at other ways of trying to improve outcomes. In other words, are we able to find a different way of approaching this problem? And so in fact in Canada we've been embarking on a major project called Evidence-Based Practice for Improving Quality, or EPIC, that has been going on for the past 5 years now. And we've been able to show that in fact we are able to continue to make huge improvements in outcomes. And over the next 5 years I think that we're going to see dramatic changes in the way we provide care as well as in the outcomes of the babies that we are caring for. In this new method of doing things, we want to obviously make use of evidence, make sure that what we are doing is based on evidence. And the principle behind it is, what can we do better with what we already know, rather than trying to find the next new magic bullet. So that's the principle of this whole effort that we're doing. We started by looking at different hospitals in Canada to see who does well in what, and what can we learn from people who do better than us in these particular areas. Now, there's no such thing as the best hospital. Everybody's good at some things and not so good at other things. So by doing that, we were actually able to demonstrate, for example, that when we studied 12 hospitals and got them to work together, altogether they were able to reduce infection rates by 44% and chronic lung disease by 15%. And that's without using any new technologies. It's based on what we already know. And so it obviously showed that that method can work and that we can still make huge improvements in outcomes by doing that. So currently we are in this next step, which is we are working together with all the hospitals in the country. All the NICUs in the country are working together on this particular effort. And we're learning from each other, and not just in infection and lung disease, but in all the major outcomes of the babies. And it's ongoing right now, and we are hoping that we will have good results after this. In addition, we are embarking on another innovation, which is we go around the world instead of just in Canada, and to see where in the world there are specific areas of extraordinarily good outcomes and what can we learn from them. And then take these ideas back, test them, see how they work in our own context, and then create a new way of managing babies by integrating all these best practices from around the world together with our own best practices. And if we can do that, then we will be able to produce the best outcomes in the world. So I'll give you some examples. One of the ideas that we are currently piloting is something we're calling family integrated care, as opposed to family-centered care. Now, in the past, everybody has been doing what we call family-centered care, and the idea is that we want to involve the families more. But still, it was very much the baby was being cared for by the nurse, the doctor, and the care team. And we try to involve the parents more by explaining more to them, by having them visit, hold the baby, and things like that. In this new model of family integrated care, we are integrating the family into the whole care team itself. And this has been going on at Mount Sinai Hospital for a few months now. And once the pilot is finished, we'll be continuing a large-scale study, both at Sick Kids at Sinai and Sunnybrook in Toronto at all the hospitals. In this model, the parents are actually part of the care team, and they provide care for the baby, primary care for the baby. In other words, the mother, for example, will do everything with the exception of IV and IV medication. She provides care for the baby on a day-to-day basis. She gives medications to the baby. She writes in the charts. She participates in the ward rounds and gives her opinion about what should be done, etc. So that she's in fact the primary caregiver. The nurse's role changes from being the person who cares for the baby to being the person who teaches the mother how to care for the baby. So this is a huge sea change. It's a dramatic change in the roles of the caregivers. It's a dramatic change in the roles for the parents. And the response has been phenomenal. The parents really love this. And I'll give you an example. One of the parents said to me, "Thank you for allowing me to be a parent." Because in the past, all we could do was visit, and the baby felt like it was not our baby. We had to get permission from the nurse every time we wanted to do something, even to touch the baby. Now, I can do everything, and I know how to do everything. They're also more confident, so that when the baby goes home, they actually know what they're doing, as opposed to now they are nervous, they don't know what to do. Baby's been very sick for a long time, etc. Now, when this thing was actually tested in Estonia, where the idea actually originated, they found a 30% reduction in infection rates, 30% improvement in weight gain, 20% reduction in length of stay, and a 50% reduction in nurse utilization. So in other words, they could get better results at lower costs, and improvement in satisfaction from both nurses, doctors, and parents. So we are looking at how we implement this in our Canadian context, because our society is different. Obviously, we cannot just take something and do the same thing. We have to do it differently. And so we've had teams, multidisciplinary teams of doctors, nurses, therapists, working together with parents. And these teams were led by the parents. They were designed by the parents to make it work, because they have to work for the parents. And like I said, the response has been phenomenal at Mount Sinai in the pilot. And we're going to be starting the pilot here very soon. And I think this is the way of the future, where the parents are going to be, in fact, the integral part of the care team. That's one example. Another example is, for example, looking at integrating the babies from the NICU into society. One of the big problems in the past has been that many of these babies, after they leave the NICU, in fact, have problems. Learning disabilities, cerebral palsy, behavioral problems, etc. And we have not had good mechanisms for how do we integrate into society. And the families actually tell me that most of their problems start after they leave the hospital, not while they're in the hospital. When the babies go home, then what happens is they have to enter into the general healthcare system. They have to enter into the school system, etc. And they're actually not that well set up to look after these babies because they do not understand the specific problems that these babies face. And so we have something called a follow-up clinic, which assesses these children up to between 3 to 6 years of age. And the idea is to see what problems they face and then to try and give them a referral so that they can go to the right services in society. But after 3 to 6 years of age, they're on their own. And that's when the problems really start, because there's no one there now helping them figure out how to negotiate the system. And I had one parent who was actually a very well-to-do parent who said to me, after we finished the follow-up program and my child started going to school, we had the biggest problems because we had to negotiate a system that did not understand how to deal with our children. And so he said, imagine me in my socioeconomic status having this kind of problem. What problems would a parent with less means have? So we're starting another pilot program here in Toronto, where we're actually going to bring different kind of teams together. This team will include not just neonatologists who do neonatal follow-up assessments, but also people who are skilled in developmental pediatrics and who are skilled in education and so forth. And they will work as an integral team together with our social, health, and education services to design how we will program these kids beyond the follow-up time into the community. And also then work to train and to prepare teachers in the schools, special education teachers, doctors in the community who are looking after these children, how they can actually help these children. And we hope this will actually be better in terms of developmental optimization for these children and care for the families. I'll then go forward with another idea, which we're also currently testing. Now, in the past, it has also always been considered that when a baby is admitted to the NICU, the baby is the patient, and the family isn't. So the whole team and the whole hospital is designed to look after this patient. We think that's wrong. We think that, in fact, the team should be designed to look after the family. Because it's not just the baby that has problems. The family is now facing a whole variety of different kinds of problems. Everything from the mother, her own medical problems post-delivery, to psychological, stress, all kinds of other issues. We think that the family, we need to care for the whole family and not just the baby. Because the family is a whole unit. And the baby is just one part of that unit. And just to look after the baby and ignore the rest of the family leaves them with tremendous issues. The families face a lot of psychological problems, stress, there's emotional problems, there's distress between the parents, between other siblings, there's financial problems, etc. And so the team needs to be constructed to look after the whole family and not just the baby. And that means that the team must include other expertise. For example, we need to have a doctor on the team that looks after the medical issues of the parents if they have any, or the siblings. We need to have a clinical psychologist who deals with their stress issues and their emotional issues. We need to have a therapist who will help them cope with these problems. Because what you want is to optimize the conditions for when the baby is able to go home. In addition, if the family is going to be an integral part of the care team looking after the baby, they will do their best work when they themselves are cared for and they are in good health, both mentally and physically. So that's a concept that we're going to be developing and building in the nursery. I mean, the other reason we have a family integrated into the care team is that, you know, when we have healthcare givers looking after families and after patients, the doctors change every shift. The nurses change every shift. There's actually no one who really knows the baby on a day-to-day, minute-by-minute basis because the staff's always changing. The mother or the father there all the time gets to know the baby really well. I'll give you an example. Last month, when I was on service, one of the babies developed a sickness called septicemia, which is an infection, and became very ill. And the mother said to me, 2 days ago, I knew my baby was not well. And I kept telling the nurse my baby was not well. But she checked the baby and said everything was fine. But I knew my baby was behaving differently. There was something wrong with my baby. And that kind of knowledge only comes when you really know your baby really well, you know. So it's really critical that I think when we go into this mode of having families integrate into the care team, I think we will see amazing results. The other things we're going to be doing, for example, in our current care for babies, we often use ventilation, for example, to help babies to breathe. Now, the usual way in which we provide ventilation is that if the baby cannot breathe well, then we give the baby some CPAP, in other words, some air or oxygen under pressure to help them to breathe better. If that doesn't work, we intubate or put a tube into their lungs, and then we use a machine to breathe for them. And if that fails, we go to what we call a high-frequency ventilator, which is a more sophisticated kind of machine, where we put a tube into their lungs, and then this machine vibrates the air into their lungs. And if that fails, then we have to do heart-lung bypass, or ECMO. Well, in Germany, in Cologne, what they have tried to do is turn the thing on its head. Instead, they're using high frequency as a first resort rather than a last resort. So the baby cannot breathe well. What they do is that they put the baby on a high frequency ventilator right away, but not by putting a tube into their lungs. They put it on a mask. And they put a high frequency ventilator with the mask, and the baby is breathing on its own. And we've tried that. In fact, it works very well. You know, it probably works somewhere between a bubble CPAP and a high frequency ventilator. But it's much less traumatic. It doesn't require intubation. It doesn't require the high pressures, damaging kind of things that the machine can provide for the baby. And so these babies then breathe on their own on this high frequency ventilator through the CPAP, and they do just fine. So again, we have another pilot that we're now testing, and then we'll go into a full trial to see this new mode of ventilation. And in fact, you know, if it succeeds, it can be used potentially for different varieties of ventilation at a much less traumatic way of managing these babies. I'll give you another example. We are testing another method now. Again, the pilot is happening at Sinai, and then it's regarding resuscitation. So currently, we have something called the neonatal resuscitation program, which tells you how to manage a baby. When a baby is born, you need to get a heart rate up to over 100. You need to get the O2 saturation up to over 90 within 1 minute, because we are worried that if you don't, you're going to damage the brain and all kinds of problems. Well, in Cologne, they are questioning that, and they're saying why. Because when a baby is inside the mother, the oxygen is only 40. So why does it happen that when a baby comes out, it needs to be 100 within 1 minute? And why does the heart rate need to be over 100 within 1 minute? And if you think about it, resuscitation started with adults. People had a heart attack, the heart stopped, so we do cardiac massage and do all kinds of things for them. The baby's not the same. First of all, the babies are not dead. They're just transitioning from in utero to extrauterine life. Secondly, they are used to a low oxygen environment. So why do we need to suddenly give them a high oxygen environment? No. So we are testing a new method now at Sinai where, in fact, we're giving the babies 3 minutes instead of 1 minute to adjust. And for the first 3 minutes, we do nothing except support them. We keep them warm, we give them CPAP, and we allow them to sometimes transition. And the experience in Cologne has been that, for example, babies under 27 weeks, in Canada we would intubate and ventilate probably 95% of them. In Cologne, 1% get intubated and ventilated. The rest are managed only on CPAP. And not only that, the outcomes are much better. They have much less lung disease, they have fewer brain hemorrhage, fewer infections, and they can feed much faster and grow better and so forth. So this is something that we are currently testing. We're developing a new protocol and testing this, and the pilot is actually going very well. You know, in the last 2 months, we have actually had about 10 babies, and only 1 baby required intubation. Everybody else was managed without intubation. I'll give you another example. One of the biggest killer of babies is infection of the intestines called necrotizing enterocolitis. And many very small babies would develop this problem, and then they have infection of the intestines, they have perforation, peritonitis, many of them die, and it's a very serious condition. About 7% of our babies less than 1,500 grams have this problem. In Japan, it's 0.5%. Okay? And they used to have 7% too, but now they have 0.5%. And when you go and see what they do, in fact, it probably comes down to a few very important things only. The first thing is that they only allow human milk in the nursery. They do not allow cow's milk, period. All right? And if you think about it, cow's milk is meant for cows, and human milk is meant for babies. So why do we feed cow's milk to human babies? They actually do not tolerate it, particularly if they are premature, their intestines are not well formed, etc. And there is good evidence in the literature that if you use only human milk and you do not use cow's milk, you can reduce the incidence of necrotizing enterocolitis by 85% and reduce infections by 50%. Right? And the reason is that human milk is not only optimized in terms of the formulation for the babies and easy to digest and absorb and so forth, but it also includes antibodies, antibiotics, etc., that in fact fight against infection. And therefore it prevents infection from happening. Right? So it's protecting the babies. Right? Now what happened was that in the 1980s, because of HIV, everybody was fearful. So we got rid of all the milk banks, and we brought in all these fancy new formulas that we thought were going to be very good. But we're learning now that in fact that's not the case. And so we're now starting to build milk banks again in Canada. We're going to bring donor milk in, and once we've done that here in Ontario, we're in the process of doing that now, we will remove cow's milk from the nursery, and we'll only use human milk. If the mother cannot produce milk, we will use donor milk, right? And we think that that's going to be extremely important. Now we've piloted that. We've had 2 hospitals now, one at Sunnybrook and one in Vancouver, where we have done that, and we've only used human milk. And we've brought the incidence of necrotizing enterocolitis from 7% to 1%, just by doing that. Right? So in fact, I do not agree that it's going to take that much more effort to improve our outcomes dramatically. I think what has happened is that we have failed to realize that we actually can do a lot more with what we already know. Secondly, that many of the gains that we can achieve can be done without a lot of huge investments in new technology or medications, etc. It's simply doing better with the things we know and applying technology appropriately, because currently we're not using many of these things appropriately. Right? I'll give you another example. Jehovah's Witness. They do not allow blood transfusions in their religion. And so what happens is that if a baby is from a family of Jehovah's Witness, they come to the hospital, we minimize blood tests. Right? So we avoid doing as much blood tests so that we do not have to transfuse these babies. Most of the other babies get a lot of tests done to make sure we are monitoring everything is correct and all that. But the Jehovah's Witness babies, we minimize them so that they do not need blood transfusions. But yet, if you look at it, these babies actually do just as well. Right? So we must ask ourselves the question, why, if in a Jehovah's Witness baby, we can avoid doing all these tests and they do just as well, do we need to do all these blood tests in a non-Jehovah's Witness baby? Surely, we can apply the same principles, get the same information that we need, and get this equally good results without doing all these unnecessary tests and incurring the cost for them in addition. We also know that when you transfuse babies, there's a risk. In fact, there's a description now of the fact that, in fact, many of the babies with necrotizing enterocolitis, the necrotizing enterocolitis actually occurs within 72 hours of a blood transfusion. And there's good physiological reason to believe that, in fact, the transfusion actually causes the necrotizing enterocolitis. So, minimizing blood work, reducing the need for transfusions will, in fact, solve a lot of these problems. All right? So I think what you're going to see as we evolve forward is a more thoughtful way of caring for babies, a more compassionate way of caring for babies, so that we will, in fact, provide gentler, kindler care, more compassionate care, more appropriate use of technology, more appropriate use of resources, more involvement of the families, so that, in fact, they are part of the care team and provide better care, because there's no better nurse than a mother or a father, right? We will also have to look at how we program these babies into the community so that we can optimize the outcomes. We will have to learn to care for the entire family and not just for the baby. Now, to do all this will require a lot of rethinking. First of all, is all the technology that we have appropriate, and is the way we use it appropriate? Do we have to redesign them? Are our facilities appropriate? For example, our NICUs are all open wards. If the parents are going to stay and be part of the care team, we will need facilities for parents to stay, be comfortable, be able to interact with the staff and with each other, and so forth. We would have to utilize the roles of our staff differently. Our nurses become teachers, for example. Our parents become caregivers. But parents will also teach each other, and they will be buddies and teachers to other parents, you know. So the roles of parents are going to dramatically change, and they're going to be an integral part of the care team. All right. We will develop new kinds of expertise. Parents potentially will become teachers in the NICU. They'll become caregivers, they become mentors, become buddies, counselors to other parents. We will have staff on the NICU who are going to be looking after the families as opposed to the baby, and working together as a part of the care team. All right, we'd have to redesign the NICUs so that it would include, you know, spaces for the families to live in, bedrooms for the mothers, right? So the current trend, for example, to a single room design where each baby has its own room and there's a bed for the mother is probably the way we would have to go. Whether that's the right design remains to be seen, and there may be some modification of that, but certainly that kind of a design where the parents have a place to stay would be important. We would have to provide comfort for the baby, for the mothers and the families, right? So we would have to have lounges, kitchens, playrooms, gyms, whatever, so that the families, in fact, can actually spend time here and be able to be comfortable in this place. We would have to redesign the whole system, not just in the NICU, but throughout the whole country, so that it's not just level 3 facilities, but a level 2 and a level 1 have to have the same facilities. The mother who is caring for the baby as part of the care team in the NICU is not going to accept being told that she now cannot do it when she's transferred back to the community hospital. All right? We would have to redesign the whole way we teach people and what they do. For example, resuscitation program. If in fact we have a new way of resuscitating babies, we would have to redesign a whole way of teaching people. We would have to retrain all our staff across the country. Right? We have to reallocate our resources, because some of the babies that have to be born in a tertiary center now may not need to be born in a tertiary center. In fact, with this kinder, gentler approach, we can probably do more in the community hospitals and so forth. So I think that all in all, we're going to be looking at a whole new era where the care will not only be better, the outcomes will be better, the costs will be reduced, satisfaction will improve, and outcomes of babies will be better. We are anticipating that this whole series of programs that we are doing, we hope will result in an improvement in outcomes of between 70 to 80%, reduction in mortality and morbidity, including long-term outcomes. So for example, in the very small babies now who are less than 27 weeks, for example, in 26 weeks and below, 70 to 80% of these babies eventually have learning disabilities, behavioral problems, etc. And we think we can reduce that to 20%. Right? Cerebral palsy rates will come down dramatically, and so forth. So I think that, in fact, we are on the cusp of a major new advance in the way we manage these babies that will result in much better outcomes. And we don't necessarily have to have new technologies to do that. When the new technologies come, we will have another leap. Right? But the next 10 years will see a dramatic change in the way we care for babies and a huge improvement in outcomes. I think there has to be a more thoughtful way of proceeding forward. What has happened, as you rightly point out, is that development of technology, first of all, tends to be reactive. And secondly, it tends to be sporadic. In other words, somebody comes with an idea and they run with it and they create a new way of doing things. And then it gets implemented without actually having been properly tested and figured out how we actually should be using these things. So I think that what needs to happen is that the caregivers in the hospital, the parents, and technology companies and creators of technology need to be working more closely together as a team, to be more thoughtful and to think forward, to strategize how we can actually use technology in an appropriate manner and in what way this will actually optimize the care for the babies. And until we do that, you know, we're going to continue to see the kinds of things that we have and realize after investing lots of money into a technology that is in fact not doing what we had hoped it would do. I think there have been a lot of developments in recent years. I think in terms of the natural history of neonatology, we made huge advances from the 60s to the 80s. And then from the 90s to the 2010, you know, we did not really have any real improvement. I think we're going to see another great leap forward now over the next 10 years as the kinds of more thoughtful neonatology happens and in appropriate use of technology happens. I think what will happen now is that as we move forward, we will begin to usher in a whole new era of management because we're now in an age of accountability. Not only is society asking us whether or not we are doing the best job, but they are asking us to prove it. Now that's been a good thing because it has forced all of us to begin to make sure that we can actually account for what we are doing and to measure what we are doing so that we know the outcomes better. And so now, in fact, we have many countries around the world where, in fact, there are databases and there are reports annually and on a regular basis about the outcomes, and people can see whether you're doing well or not well. That has also led to a huge amount of sharing of information as the information technologies move forward, so that now we can begin to more quickly look at what are the differences between different countries and hospitals, etc., to find out what are the things that we can do better at. Now, in addition, with the evidence-based medicine era, we're now developing methods for quality improvement that are more evidence-based. EPIC's an example of that. It's probably the first example of an evidence-based way of improving quality, because quality improvement in the past has been very non-evidence-based. And so now we have plotted a way forward for how we can improve quality of care in an evidence-based way. And the work that we have done in Canada has been something of that has been taken up by many other countries. So that in fact many other countries have come to us to ask us to help them develop this. And we've now developed EPIC teams, for example, in all the NICUs in Canada. 30 hospitals in Canada have now got EPIC teams to improve quality of care. But in addition, we've developed EPIC teams now in 6 countries in South America: Ecuador, Chile, Brazil, Argentina, Colombia, Peru. We've developed EPIC teams in China, in Malaysia, and very soon in India. And so many other countries have realized that this is a right way to go, and they have come to us for help, and we are helping them to develop that, and we're working together collaboratively so that we can begin this process on an international level. So I see the future as being very bright, that there'll be a lot more international collaboration. There's a lot that we can learn from each other. Some people think that all the best ideas must come from the rich countries, and that's not true. Kangaroo care came from Colombia. The family integrated care model came from Estonia. You know, neither of these are advanced rich countries, and yet they came up with brilliant ideas. You know, so I think that as we begin to collaborate together, we'll learn more. You know, Japan came up with the breast milk and the strategies for reducing colitis. Germany came up with resuscitation, etc. And as we begin to process the information more quickly, I think that outcomes will improve more rapidly around the world.